Hello, everyone. Thank you for joining us for today's webinar. My name is Mary Corey, Education Specialist for WorldLink Medical, and I will be moderating today's event. I would like to mention a few quick items before we begin. At the conclusion of today's webinar, you can submit your questions to my email address, which is mcorey@worldlinkmedical.com. Please, in the subject line, put question, and I will forward your questions to Dr. Rosier, who will answer them at a later time. Obtaining CME credits, all of this information on the slide will be provided to you in a PDF copy at the conclusion of today's webinar. This webinar is accredited for 1 hour of Category 1 CME and 1 CE nursing credit only. This program is not currently accredited for pharmaceutical CEs. This web conference is brought to you by WorldLink Medical. We provide evidence-based CME accredited education in preventive medicine and age management with a focus in bioidentical hormones. Today's learning objectives. Number 1, to review the medical literature and illustrate that high-dose thyroid replacement is not associated with any harm, cardiac arrhythmia, or osteoporosis. Number 2, to review and analyze multiple studies that demonstrate high levels of thyroid hormone are associated with increase in morbidity and mortality. Number 3, utilize critical thinking to effectively evaluate who is right and who is wrong and why. Number 4, discuss where we go from here and still provide thyroid optimization in a world that thinks thyroid hormone prescription is harmful. Today, I would like to introduce Dr. Neil Rosier, who is a pioneer and recognized leader in bioidentical hormone replacement. It is my pleasure to welcome Dr. Rosier from his hometown in Palm Springs, California. Hello, Neil.
Hi, Mary. Good morning, everyone, and welcome to the third in a series of thyroid lectures that are extremely complex. It does require critical thinking and understanding of all the different studies in order to come to the conclusions that were stated in the objectives. And of course, everyone is wanting to know, what is my opinion on the recent article that was just published in the Journal of the American Academy of Endocrinology that shows that high levels of thyroid cause osteoporosis. If you go back to part 2, I probably presented 20 to 30 studies that prove that prescribing thyroid does not cause osteoporosis. The 1 or 2 studies that did show it were studies in postmenopausal women. There were no control groups. All postmenopausal women were not on hormones, and guess what? They got osteoporosis. But there was not any other control group. So it's a neat observation, but yet everyone will come away with the thought process of taking thyroid causes osteoporosis, and therefore you should not take thyroid because it causes osteoporosis. And nothing could be further from the truth. This is going to be sort of a strange webinar in that I'm going to show you and prove to you that you should not use thyroid. I'm going to go through all the articles and all the circumstances and all the literature that shows and prove, 1, thyroid hormone does not help most people, and number 2, giving thyroid hormone can be harmful in most circumstances. I hope you understand that I say this tongue-in-cheek, but I'm going to explain the articles that show that based on our literature that supports that, which is what AACE wants to hang their hat on, and most of your peers want to hang their hat on too. Remember, you don't remember positive. Your brain only remembers negative, and it only remembers sensational negative and completely ignores anything that's positive. In order to be able to understand the studies that I'm going to go through, I need to review for you what I reviewed the last 2 lectures to summarize it so that we get a point in time when you can understand why I picked these upcoming articles to discuss. In the first webinar, I discussed this article was published in Neuropsychopharmacology, where all of these studies using very high dose thyroid replacement, HDT, with T3, doses that I would never think of using, and in all these studies that were followed for a long time, never once in any of these studies did they see anyone that lost bone or had osteoporosis. And this was high dose T3. We then looked at these studies that showed, well, but hyperthyroidism does. Well, that's Graves' disease. And we went on to further define Graves' disease as not being contiguous or to be confused with high dose replacement. Graves' disease is an autoimmune disorder. It causes a multitude of problems. Please look at the past webinars. But when we use high dose thyroid replacement, we don't see any of the sequelae that we see with hyperthyroidism from Graves' disease. But the upcoming articles I'm going to show you talks about suppression of TSH as being hyperthyroidism. And these articles that I went through in the first 2 webinars showed improved high dose thyroid when you suppress the TSH is not hyperthyroidism. You have no symptoms of hyperthyroidism. You have no symptoms of thyroid toxicity, but they still call it and term it hyperthyroidism, which is Graves' disease. You cannot and should not do that. But when we get to these studies, we'll see. The second study looked at osteoporosis, and all of these studies looking at high dose replacement did not show any adverse effect on bone degradation, osteoporosis, fractures, etc. And this is with high dose thyroid. It wasn't T4, it was T3. All of the studies that I'm going to show you utilize T4, not T3, but if you're going to see some harmful effect, you would think you would see the harmful effect with very high dose T3, which is the active thyroid hormone at the cell level. They didn't in all the studies. Please refer back to those prior 2 webinars for those articles. Now let's go forward. This first is an interesting study that showed that thyroid levels in the high normal range may be linked to cardiac arrest and death. Oh my God. So all you people out there that are prescribing high dose thyroid, you're going to kill your patients. They are at risk for cardiac arrest. People with higher levels of thyroid hormone in their bloodstream may be at greater risk of sudden cardiac death, even those levels that aren't necessarily high, really high, a new study suggests. Sudden cardiac death increases with higher thyroid hormone levels, even within the normal range. You don't have to be super physiologic. You don't have to be excessively high. You can be at the upper range of normal and still have an increased risk of sudden cardiac death. Researchers found that people with thyroid hormone levels at the high end of normal range were 2.5 times more likely to die from sudden cardiac death. Absorb that paragraph. Now you know why your peers flip out when you prescribe thyroid. Now you know why your peers and the endocrinologist flip out when you prescribe thyroid when you suppress the TSH, because you're more likely to die from that sudden cardiac death because of this high level of thyroid hormone. This potential connection between high normal thyroid hormone levels and sudden cardiac death is really new, but it raises an issue that maybe thyroid hormone is more toxic than we thought. Aha! Why do you want to give your patient thyroid hormone when it's toxic? Shame on you. Now you know why your peers have such a fit. Now you know why your peers want to turn you into the medical boards for prescribing thyroid, particularly when you suppress the TSH. It makes you wonder whether or not it puts people at risk by prescribing thyroid. Now you start to get a feel for the negativism against thyroid. In this study here, colleagues analyzed more than 10,000 patients in the Rotterdam study. They found an increased risk linked to high normal hormone levels. People most often have high thyroid levels because of an overactive thyroid gland. This is an interesting quote. The heart is working too hard because there's too much thyroid hormone around, and that makes it work too hard. I can't believe that somebody actually wrote that. And they publish it. But some people would think that. Well, anyway, you have to understand what they just said here. They said that people that have high thyroid levels have an overactive thyroid gland. This is not a study where they gave thyroid. This is a study where they looked at levels of baseline in people that were not treated with thyroid hormone. It was baseline levels. And guess what? What type of patient has an overactive thyroid gland? Patients with Graves' disease. What's the incidence of sudden cardiac death with Graves' disease? 20%. What's the risk of increased morbidity and mortality from Graves' disease with cancer? It's 20%. It's an autoimmune disorder. That's what causes the disease. That's what causes the death. And see what they did here? They linked, they assumed, they extrapolated that high thyroid levels for an overactive thyroid gland, which is most likely Graves' disease, is going to cause death. But they extrapolate that to a high level of hormone seen is what's causing the death. The heart's working too hard because there's too much thyroid hormone. That's a really neat association. That's a really neat assumption. We looked at that in the first two webinars. No, that's not true. What happens in Graves' disease when you take out the thyroid gland? Guess what? The disease progresses. It doesn't stop. When you fix the thyroid hormone and normalize it, and you put the TSH in the middle of the range, guess what happens? They still get osteoporosis, and they still get cardiac arrhythmias, and they still die of cardiac disease and cancer. Well, it's from that thyroid hormone. No, it's not. The thyroid hormone level is normal. Look at your lab test. It shows that it's normal. Then why do the people continue to die? Because it's an autoimmune disorder, and people with Graves' disease have this increased risk of dying. But they've extrapolated it, and now you can see how your peers will get hung up on this, thinking that there's too much thyroid hormone in the blood, and that's what's going to kill them. Next study, JCEM 2017. Thyroid function testing within the reference range and the risk of fractures. This is very similar to the study that just came out this week. Context. Hyperthyroidism is associated with increased fracture risk. Yes, people with Graves' disease have that risk. So what they did was they looked at 13 prospective cohort studies with baseline examinations. Keyword, baseline. Are these people being treated? No. Were they treated with thyroid? No. Well, then baseline for what? They weren't on thyroid. Yes, but they had high levels. Why did they have high levels? Because they have Graves' disease. Even among euthyroid adults with early Graves' disease, I added that, low TSH and high free T4 are associated with an increased risk of fracture. We've known this now for 20 years? But when you give thyroid, it's different than when you look at baseline levels. It's a little different than the study that was released yesterday. They actually looked at treatment levels as opposed to baseline. Nevertheless, we'll move on. Conclusions. High free T4, it wasn't T3, high free T4 levels are significantly associated with an increased risk of any solid lung and breast cancer. Further research should elucidate the underlying pathophysiologic mechanism. Now, somebody that doesn't understand this would say, oh, it's the thyroid hormone that's causing the tumors. It's the thyroid hormone that's causing the breast cancer. Really? No. The thyroid hormone is elevated because of Graves' disease. Well, what makes you think it's the thyroid hormone? In order to study that, you'd have to give thyroid hormone and see if the study actually results in increased risk of cancer. Any study in 50 years will we see that? No. What about Graves' disease? Well, yeah, when the levels of thyroid are high, yeah, you see this risk. But what happens when you give it? Well, we don't see any harm when we give it. This is all, again, baseline studies where they had early Graves' disease. They didn't say they had Graves' disease, but who else has high T4 levels and low TSH? So those are patients with early Graves' disease, and guess what? There's an increased morbidity and mortality to it. But don't extrapolate that to what happens when you give it. Go back and listen to webinar 1 and 2. Another study published in JAMA, 2017. Association of thyroid function with life expectancy, with and without cardiovascular disease. The objective was to investigate the association of thyroid function in euthyroid individuals. They weren't hyper, they weren't hypo, and they were not taking thyroid. We included participants without non-thyroid disease. If they got thyroid disease, then you'd give them thyroid hormone. That's a different category. These are baseline studies looking at baseline levels. Participants in the low normal thyroid function live up to 35 years longer than participants with high normal thyroid function. These findings provide supporting evidence for a reevaluation of the current reference ranges for thyroid function and can help inform and prevent adverse effects. What they've done again is they've looked at a baseline association and have extrapolated it to causation, and therefore say, well, guess what? Because high thyroid is associated with harm, we shouldn't bring the levels up when we give it. No, that you can't make that assumption, but everyone does. You wonder why our professors told us in school association does not prove causation. You wonder why I've said that 1,000 times in the courses, but yet these experts that write the papers, these experts that publish, still don't grasp it. It's fascinating. International Journal of Endocrinology, the relationship between subclinical thyroid dysfunction and the risk of cardiovascular outcomes, meta-analysis. This looked at subclinical hyperthyroidism, defined as suppressed TSH, was found to be associated with increased total mortality. Well, yes, of course. Every study shows that. Every patient with Graves' disease has got a 20% increased mortality from cancer, autoimmune disease, osteoporosis, fractures, and cardiovascular disease. Conclusion, subclinical hypothyroidism is likely associated with increased risk of heart disease, but so is subclinical hyperthyroidism. And everyone out there that's suppressing your TSH that your doctors interpret as hyperthyroidism is going to get into trouble because you suppress the TSH, which your doctors interpret as hyperthyroidism, and it causes an increased mortality. Now you can see how important it is to understand critical thinking and being able to understand association does not prove causation, and what they're doing is they're looking at baseline levels and extrapolating harm from that as if they were patients that were being treated. You cannot and should not do that. All studies, when we give it, do not show that harm. Baseline studies, they all do, but that's purely an association. Thyroid hormone therapy for older adults. This is a great study. This is absolutely fantastic. It's absolutely phenomenal that it gets published. It's absolutely phenomenal, the conclusions from this study. I wish the endocrinologists were online to voice their opinions on this, because it certainly would be entertaining. Dr. Tannen and Dr. Kanambi, I'm sure, are chomping at the bit wanting to interject here, but this is a fun study. We conducted a double-blind, randomized, placebo-controlled trial involving 700 adults who were 65 years of age or older. They were really old. They were over 65. And they were assigned to receive T4 at a starting dose. Sorry, there's a typo. It should be 50 micrograms or 0.05 milligrams. It's 50 micrograms per day, standard dose. Results, we found no differences in the mean change at 1 year in the hypothyroid symptom score. All these patients over 65 started on thyroid. They were hypothyroid with elevated TSH, and nobody got better. If you go back to part one, I showed you a half a dozen studies where they gave just T4 alone, and guess what? The patients didn't feel better. There was no improvement in symptoms. Guess what? When you added T3, they all got better. We'll get there. Hang on. So there's no beneficial effect seen when T4 was given. Symptoms did not improve. Nothing improved. Conclusion, levothyroxine T4 provided no apparent benefit in older people with subclinical hypothyroidism. Conclusion, you don't need to treat older people with thyroid that have subclinical hypothyroidism because they don't get better. I hope all of you would have been able to predict that. I wouldn't expect them to get better. In fact, in older people, as we saw in all those lab tests I showed in part one and part two, when you give T4, what's it do? It shuts down the TSH. When you shut down the TSH, what do you do to the gland? You shut the gland's production of T3 off. And what happens when you lower the T3? The patients not only don't feel well, but they actually feel worse. We're such good doctors, aren't we? So anyway, the conclusions from this study are very, very fascinating. This is an analysis of that. There's a need for new guidelines regarding the treatment of mildly underactive thyroid gland or subclinical hypothyroidism, among senior citizens. I just discovered that I was a senior citizen, says this professor at the University of Copenhagen. After a new study has shown that the most popular treatment, T4, has no effect. In fact, senior citizens would benefit more from accepting the condition or just waiting for it to go away and pass. Really? Yeah, they don't need it. Don't give it to them. It didn't work. So what do we do for them? Just ignore them. So they just have to put up with being sick? Yeah. Well, why don't you try it? It didn't work. All the studies show it doesn't work, therefore you don't need to give it. You know, it boggles my mind that they would then not think, well, maybe we should add a little bit of T3. Maybe if we added T3 and observed and see what happened, maybe we'll come to understand, well, the T4 doesn't do any good. Maybe we need to add the T3. Don't take the thyroid away from them. Don't deny it to them. Just add T3 onto it. An endocrinologist that prescribes T3, you got to be kidding me, and publish it on top of it? Last webinar, I presented data from a couple endocrinologists, Dr. Pepper et al., that recommend adding T3 in all their patients that don't get better on T4. And when you add T3, guess what happens? They get better. Dr. Pepper's suggestion was when all this literature and data and clinical evidence supports when you add T3, they get better, then why don't you just give them T3? What was the conclusion from this study? Stop it altogether, as opposed to adding T3. It's thoroughly amazing what gets published and what's not understood. The New England Journal of Medicine shows that the drug had no effect. At worst, it can cause side effects caused by inappropriate high level of thyroid hormone. Oh my God. And I just showed you the harmful effects of inappropriately high levels of thyroid hormone. I showed you all those harmful effects. Now you can see why they're afraid to use thyroid. If it doesn't work and the patients don't get better, and there's potential harm from this high level, and I showed you that harm, then I can understand they're coming to a conclusion of don't use it. It didn't work, and in some people, having high levels could cause harm. Then don't use it. Their conclusion makes perfect sense. What doesn't make sense is the fact that they still don't understand that T4 is not T3. Our study shows that senior citizens are currently being overtreated. Many risk being treated with a drug they have no use for. It doesn't work. It does not do any good. We know that a body to a great extent is able to regulate itself. If the thyroid level is normal, perfect. If it's low, maybe that's what the body needs. The body didn't need it, so it doesn't make it. It regulates it itself. Really? And even if we allow the body time to work, like a year, most people will take a turn for the better without the use of the drug. It doesn't say they got better. Nobody got better. Well, maybe they might get better because they didn't get better with the drug. Maybe they'll get better without it. Oh, that makes sense. Well, maybe it's due to something else. Like what? Well, something else. You got to tell me what. Like what? Tell me what that is. Nobody can tell me what that is. Well, it's got to be something else. Like what? The only thing that works is T3. Well, that's placebo. No, it's not placebo. Fascinating, isn't it? That's why you have to use your critical thinking to understand this. But you also have to understand why your peers, why the Endocrine Society, and the majority of endocrinologists think the way they think and why they do what they do based on this publication. We know it is far better for senior citizens to have a low thyroid. I just showed you that. People live longer with low as opposed to high. Now that's an association. That's for Graves' disease. Don't extrapolate it to people that take thyroid. You can't do that, but they did. We know it's far better for senior citizens to have a low rather than a high level of thyroid hormone. Really? They just don't get it. It is therefore vital that we do not, per routine, treat people with a drug that has no effect and at worst causes their condition to deteriorate, and they can have side effects problems, and high levels are associated with cardiac death and osteoporosis. Now you understand why they do what they do and why they think what they think and why they say what they say. But I know you're still trying to figure out, why do they think that way? Why don't they get it? Why don't they understand it? They don't use the critical thinking and be able to analyze the different studies and what they look at. When a patient goes to see his doctor with symptoms that may be a sign of mildly underactive thyroid hormone deficiency, It can be a good idea for the doctor to just wait and see if the condition passes on its own before prescribing thyroid. Well, just why don't you come back in a year and see if you're any better? Yeah, but what do I do about my fatigue? Just hang in there. Maybe it'll go away. It's not going away. It gets progressively worse. Why don't you want to treat it, doctor? Because there's studies to show that treating it does not work. But my friend's on thyroid, and she feels fantastic. That's placebo effect. You don't want to use desiccated thyroid. That's junk. Fascinating, isn't it? The people that should know this the most, the people that should know it the best, the people that should be utilizing it to help improve quality of life and cardiovascular disease are the people that don't understand it. I find it absolutely appalling. On the back side of this article that appeared on the internet were comments. And I picked this one comment, which were sort of classic. And these are people that wrote in based on conclusions of that study. And this is an opinion of people that were on thyroid. Regardless of age, not everyone converts T4 to T3. And why that medication doesn't work well for many people? Because it doesn't convert. And you shut down what is being produced by the thyroid gland, which actually lowers the T3. We saw all those labs in part 1. Give them T4, the T3 falls. Natural thyroid such as Armour thyroid, there's other ones over in Europe, with T3 and T4 works much better for many patients. And some do best on straight just T3 alone. What a concept. First, we're offering a medication that doesn't work for everybody, and then all hope is removed by offering nothing. I couldn't have said it better myself. Isn't that fascinating? The patients get it. The public gets it. The endocrinologists that write the studies don't. Another comment, well said. I've been hypothyroid for years and really do know how much medication I need to stay even and halfway well. GPs only take the TSH lab results into consideration when assessing how much to prescribe. If you scream and shout, the more sensible ones will ask for T3 and T4, though many hospitals won't sanction it. Again, it's outlawed in Great Britain. I saw a specialist privately, and he told me the only person who knows how much thyroid one needs is you. Several years before your thyroid fell apart, because we really don't naturally need to produce the same amount in different individuals. Some people need more, some people need less. Every year my med review is a battle because my GP wants to reduce my medication. And if he does, I know that I will be heavily overweight, depressed, cabbage, who can't stay awake for long after breakfast and couldn't do the daily mirror crossword. Angry simply does not cover how I feel. This is the pushback from the patients, but it's interesting the pushback that you get from the endocrine societies and the endocrinologists, internists, family practice docs that read this study in the New England Journal of Medicine and say, you simply don't need it and it could be harmful, don't use it. And everyone completely rejects, ignores. You can make all these people so much better by just simply giving or adding T3. Oh, no, you don't want to do that. That's harmful. And you understand why they say it's harmful. You can't argue back. Just deal with it. Moving on. More criticism for using thyroid. A 75-year-old woman presents to your clinic for a visit. Her TSH level comes back at 0.1. I don't think I have any patients that I've treated with thyroid that have TSH levels above 0.1. But that's another lecture. We think, however, that this case highlights a problem with critical importance, the overuse of thyroid replacement, particularly amongst older patients. And I explained to you and showed you why they think the way they think and why they know it's bad. In our experience, too, patients with nonspecific symptoms like fatigue, low energy, or constipation get a TSH check as part of the regular workup. If the level is elevated, the treating clinician will frequently start with levothyroxine, which study after study after study shows it doesn't work unless you add T3. Now, an important new study published last month in the New England Journal of Medicine demonstrates that the treatment of mildly elevated TSH levels does not have any benefit when the free thyroxine level is normal. So even though if your TSH is elevated, indicating subclinical hypothyroidism, If the T4 level is normal, that's the free T4, they don't need it. They don't need it. It doesn't work. It's only going to cause harm. After a year, the levels of tiredness and scores on a thyroid-related quality of life survey were not any different in the two groups, placebo versus those that got T4. In fact, previous research has shown that when T4 is initiated, the dose is often too high. Why do people want to keep prescribing such high dose of thyroid? Because that's where they feel better. Yes, but look at all the harm that you're causing. What harm? Well, all these studies show harm. No, that's baseline. Don't extrapolate baseline levels to what happens when you give it. One study found that an astounding 58% of patients started on thyroid replacement have an excessive low TSH, suppressed to below 0.1 after 5 years. Oh my God. And we saw all the harm that causes. Interestingly, though, however, the majority of the patients that I've seen that come to me that are treated by endocrinologists, all those patients have TSH levels less than 0.1. Why? Well, they can measure free T4 and free T3, and if it's normal, no, they don't have hyperthyroidism. But people extrapolate that TSH is harmful because studies showed suppression of TSH is harmful. No, it's not the suppression of TSH that's harmful. It's the autoimmune disorder of Graves' disease that's harmful. And yet, all these studies, when we suppress the TSH, we haven't seen harm even in very high dose replacement. Moreover, overtreatment of hypothyroidism has clear downsides. I already went through that. They may develop complications such as atrial fibrillation and osteoporosis. Go back to webinar 1 and 2 and look at all the studies where high dose replacement did not result in any atrial fib, cardiac arrhythmias, cardiac death, or osteoporosis or fractures. What's the new take-home message here? While asymptomatic patients with subclinical hypothyroidism, which is an elevated TSH, require close monitoring, they frequently should not receive thyroid replacement unless their TSH levels are persistently and substantially above the reference range and they suggested levels greater than 20. What about the free T3 at 2.0? You ignore that. Don't worry about it. Isn't it fascinating? They completely ignore the thyroid hormone at the cell level in a free T3 and thoroughly rely on the TSH. After 40 or 50 years of all these studies showing that the TSH is not reliable as far as symptomatic improvement, everyone completely ignores it. This is so very fascinating, which is why I'm so passionate about it. In the meantime, slow medicine principles suggest that we should be cautious about initiating thyroid hormone therapy in such patients. I would think it should say they should be cautious about initiating pure T4 in these patients. Because in most cases, the symptoms are unlikely the result of thyroid disease. How do you know that? Well, because we gave it to them and it didn't work. Well, what makes you think it's not thyroid? Well, because they should have gotten better. No, they should have gotten better if the T3 level went up, but all the T3 levels fell. But T3 is a lousy test. You don't want to test it. So therefore, the poor patient suffers. Isn't it fascinating? When we do initiate therapy, be vigilant to discontinue the medication if the patient's symptoms do not improve. And don't even think about giving them T3 to try to get their symptoms to improve, because we just don't do that, and they don't need it, and there's potential harm, et cetera, et cetera, et cetera. Now you see why they say what they say, and now you see the path that they go down, and now you understand the resistance. If you're going to prescribe thyroid, sorry, you need to do it carefully, you need to do it cautiously, and as I've taught through part 1 through part 4, if you're going to involve another physician in your management, then I cannot treat you with thyroid. Hey, but what do I do? You suffer. Really? Forever? Yes. Can't you call my doctor and explain it to them? No. Have them go listen to this webinar. And they'll say, yes, everything he says is true. All those studies show high levels are harmful. That is true. I understand that. Moving on. Let's look at more harmful things. Inappropriate use of suppressive doses of thyroid hormone and thyroid nodules. Results from a nationwide survey. In part 1, I presented a couple articles where the ENT doctors recommended TSH suppression for treatment of thyroid nodules. They didn't recommend surgery, which has its risk. They just recommended suppressing the TSH to 0 with thyroid hormone, and the thyroid nodule will shrink. Current guidelines endorse synthetic T4 monotherapy as the mainstay of hypothyroidism treatment. Of course. If you understand politics and economics, you'll understand why that is the case. Since 1996, guidelines have been recommended against use of thyroid hormone in suppressive doses for thyroid nodule management. This is because of the potential harm of iatrogenic hyperthyroidism that outweighs any benefit. Again, the iatrogenic hyperthyroidism is, as per their definition, suppression of TSH. If you go back to the first webinars, hyperthyroidism and thyroid toxicosis and symptoms of thyroid excess define excess thyroid replacement. Suppression of TSH has no role in that whatsoever. But every time someone sees a suppressed TSH, they will immediately state and attribute it to being hyperthyroidism. Adverse effects of iatrogenic hyperthyroidism include cardiac and skeletal risk, especially in older individuals. That causes cardiac death, osteoporosis, blah, blah, blah. Almost 1/4 of surveyed physicians use thyroid hormone in suppressive doses for thyroid nodule management. Really? Other unconventional indications for thyroid hormone use were also reported. Fatigue, depression, weight gain. Why would you use thyroid hormone for weight loss? Despite AACE and the Thyroid Association guidelines against thyroid hormone use in suppressive doses for thyroid nodule management, we found that this practice is still being employed by close to 1/4 of 25% of all physicians. Interesting, isn't it? What, we don't believe them? Why don't we listen to what they have to say? You don't believe what they say? You don't believe all those studies? Well, when you use critical thinking and analysis, you'll understand why the studies show what they show, but what you should take away from those studies and not extrapolate or assume. Continuing, it is worrisome that this inappropriate use of thyroid hormone continues, especially the elderly who are more vulnerable to harm from suppressive doses of thyroid hormone. I went through all those studies to show that suppression of TSH is not harmful with high-dose replacement. But low TSH that is suppressed is harmful because of Graves' disease, but they don't make that distinction in this discussion. Potential risk of adverse effects of TSH suppression in differentiated thyroid cancer. In these cases, T4 doses should be monitored to achieve the objectives of inhibiting TSH suppression below 0.1, but also avoiding clinical hyperthyroidism, i.e. symptomatology of palpitations, jitteriness, weight loss, sleepiness, etc. There are many studies on the potential harmful effects of suppressive therapy on various organs and systems with discrepant results. However, again, yes, I showed you all those studies showing that suppressed TSH or high T4 baseline is harmful. However, when you treat someone, there is scientific evidence that the clinical impact of these effects is significant. What was left out there was, there is no scientific evidence, Mary left out a no, there is no scientific evidence that the clinical impact of these effects is significant. Yes, but it can suppress the TSH. So what studies showed that suppressing the TSH by giving it was harmful? Well, all these studies showed low TSH is harmful. No, that's baseline studies. I want to see a study where it's harmful when you suppress it, when you give it. Part 2, I showed 20 studies showing no harm. But yet, everyone thinks because they extrapolate baseline studies. This is a little article from Thyroid News and Research that I found interesting, that you may find interesting also. Guidelines are skeptical about adding T3 to T4 therapy to treat for hypothyroidism. Guidelines are skeptical. This is because the guidelines say you don't need it. Don't do it. It's harmful. It didn't work. We'll get there. But some patients are convinced that the combination works better for them. We've all seen hundreds, if not thousands, of patients where it does. And we've seen hundreds, if not thousands, of patients that get told by the doctors, they don't need it, stop it, don't take Armour Thyroid. Your hypothyroid patient complains that she still does not feel well despite taking T4 alone. She's been researching on the internet and has read many accounts from patients in her situation say that they feel much better when the doctors add T3 or something, that a hormone called T3 onto their T4. Yes, that's true. And clinical trials have not found a benefit in adding T3. Oh, yes, they have. No, they haven't. Yes, they have. No, they have not. It has worked for some patients to take T4 and let the body do the conversion. It's great if you're under 30. 5 to 10% of patients say it doesn't work for them. Is there a problem giving these people T3 as well if they feel better on it? Well, they don't need it because studies show it didn't work. No, studies show it did work. No, studies show it didn't work. Let me split hairs. There's multiple studies and multiple meta-analyses that show that taking T3 in addition to T4 does not add any benefit, period. Put it to rest. We don't need any more studies. However, people have gone back and looked at those studies, and in those studies, they always use around 5 micrograms of T3, which is worthless. In all the studies where they use 20 micrograms of T3, guess what? It worked in every study. So if you want to say it doesn't work, sure, there's lots of studies to show it doesn't work, but they use 5 micrograms of T3. If you want to show studies that work, those are studies where they use 20 micrograms of T3, and it worked great. But you can see how the Endocrine Society will use all of these studies that show that it didn't work to show and prove that you don't need it. Yes, but if they feel better on it, why can't you give it to them? Because they don't need it. Really? But why don't you try it just to see if they feel better? No. Interesting, the attitude that they have. It is unquestionable that some patients will tell you that the day they were switched from T4 alone to combination treatment, a light bulb went on in their brain, or that they can suddenly think again. But they don't need to think again. They don't need a light bulb in their brain, so don't give it. The American Thyroid Association's latest hypothyroidism guidelines in 2014, which concluded that T4 should remain the standard of care. We found no consistently strong evidence of the superiority of adding T3 or using thyroid extract or desiccated thyroid. They found no consistent strong evidence, but if they really were to look at it, all the studies that showed that it didn't used very low doses, and all the studies that used a good dose showed that it was beneficial. What is it that you guys don't see? Well, they don't want to see because politics and economics. That's another lecture for another time. There's currently insufficient evidence to support the routine use of a trial of combination of T4 and T3. Really? Well, because so many studies show it didn't work. Yes, but the doses that they used were so low. We just don't have the data. Excuse me? There's plenty of data. There's tons of literature. There's many studies. Yet, according to this guy, they don't have the data to change his mind. Really? Why do you ignore all that data? Why do you ignore all those studies? Because they can. This is the director of endocrinology. Well, gee whiz. Imagine what their agenda and what their bias is. Combination therapy should be considered solely as an experimental treatment. Well, it looks like I experiment on hundreds of patients, and guess what? They get better. Isn't it interesting, the pushback? They completely reject it. There's not enough data, there's not enough studies, and they completely don't understand it. The most recently published guidelines from the Italian Thyroid Association in 2016 says that combination therapy is generally not recommended. But combination therapy is clearly in use. Bianco estimates that nearly 50% of the hypothyroid patients referred to him are on it. We don't recommend it, but 50% of the people are taking it. Really? Why? Do they think that no, it doesn't work until you add T3. That's where they feel better. If they didn't feel better, they wouldn't be taking it. Well, guess what? 50% are taking it. There are 10 to 20 studies designed to look at the combination therapy in a systemic manner using different ratios of thyroid T4 to T3. For the most part, none of these studies showed any consistent effect. That is because the studies looked at ratios of 1 to 10 to 1 to 14. There's a real nice study published in JCEM that stated that T3 should be given in a ratio of 1 to 3. So if you have 30 micrograms of T4, the T3 should be 10. All these other studies, they gave 100 micrograms of T4 and they added 5 micrograms of T3 in a ratio of 1 to 20. It's just ridiculous what they do, but they have an agenda, and their agenda is to show and prove that it doesn't work. Interesting, isn't it? For the most part, none of these studies showed any consistent effect. Of course not. That's because they use such low dose. I always use the example. Patient comes in with a kidney stone. I give him 1 milligram of morphine. It does nothing. Therefore, I prove that morphine doesn't work. No, what it proved was the dose that I gave didn't work. When you give them 10 to 20 milligrams, they're sleeping like babies and the pain's completely gone. Yes, but we did a study that showed that 1 milligram didn't work, so therefore you conclude that it doesn't work. No, what you should conclude is what you gave did not work because you simply did not give enough. The T4 in your study didn't work because that's all you gave was T4 and you didn't give T3. Well, you don't want to give T3 because too much can be harmful. Just simply stop it. No, what you should do is add more in the form of T3. That's what the study showed. That's where they got better. That's why 50% of the people are on T4, T3 combinations. But they just reject it. It's very interesting. For meta-analysis, the literature concluded that there was no consistent benefit to adding T3 to T4. Well, of course. There's 1,000 studies out there showing that 1 milligram of morphine did not work. Therefore, we should not use it. It's very fascinating, the logic, or lack thereof. But the effectiveness of the combination therapy remains an open question because of the flaws in the previous studies and lack of well-designed randomized trials. Well, there's lots of randomized trials that are well-designed that showed benefit, but those studies are ignored. We'll get to that in another webinar. In the 13 or so combination therapy trials that have been done so far, the majority only gave T3 once a day and a dose of 5 micrograms. Few of them gave it twice a day, but that still isn't enough. And that really isn't enough to maintain nice steady levels of T3. You're going to have 10 at the minimum BID, typically 20 to 30 BID, then that's when they see improvement. That's when the light goes on. But yet they still reject it and resist it. Very fascinating. But now you understand why they reject it, because of the harm that I showed you in those first studies. Correct dosing might require taking T3 several times a day. Yeah, 2 or 3 times a day. The clinical literature is muddled by the fact that most people who have tried to give T4 and T3 have given way too much T3. Really? I think it's just the opposite. They don't give enough. If they gave enough, then you'd see that it works. Basing treatment on patients' preferences may not lead to the best outcomes. T3 has also been used by psychiatrists as adjunctive therapy for depression. So part of this feeling better issue may have to do with the fact that the effects of giving too much thyroid hormone. It may simply be that being slightly hyperthyroid, people feel better. No, people with optimal levels of T3 feel better. They just can't grasp it. But the patients are wedded to it. Yeah, put somebody on it, make them feel better, and then try to say, okay, stop it, take them off of it. They won't. As long as you're not doing any harm by taking too much T3, I'm certainly willing to continue to be supportive of their care. There is a problem with using supraphysiologic levels of T3. Go to webinar 1 and 2. No, there's not. So I don't suggest anyone take thyroid extract. But if you provide T4 and T3 at the appropriate ratio, why should that be considered to be problematic? It's not. But it is really a crying shame that it's the patients that have to demand it, and it's the patients that have to tell the doctors what to do. That's what I find so very fascinating about this whole topic. So let me talk a little bit about the study that was just published. Dr. Vanita Tandon from Jumpstart in San Francisco and Dr. Shuk Kadami immediately sent me emails about this article. And it was cute. Dr. Kadami's wanted me to mention the conclusion of the article was that suppressing the TSH with thyroid hormone causes osteoporosis and fractures. And the treatment for that should be to use biphosphonates. So, hey, Ashok, maybe you and I should get together and we'll combine a biphosphonate with T4, we'll patent it, and do a study, shows that it works, so bring it to market. How's that sound? I hope some of you found what I just said absolutely disgusting, because Dr. Kadambi said there was no mention of using hormones in this study whatsoever. So anyway, this study that was just published March 2018 in the Journal of Clinical Endocrinology and Metabolism. Thank you, Dr. Tannen, for sending that, and Dr. Kadambi. The title of the article is Vertebral Fractures in Women on Thyroid Stimulating Hormone, Suppressive Therapy for Thyroid Carcinoma. So what they did was they looked at 3 groups of women that were taking T4. All women were 59 years of age or older. All were postmenopausal and not on hormones. And they were giving various doses of T4, and they looked at TSH levels. They didn't look at T4 levels. They looked at TSH levels. Well, really what you should be doing is looking at T4 levels and T3 levels, don't you think? And don't you think that you should have a control group in there somewhere? There was no control group. There was no patient group that was on placebo. Well, of course not, because they were all receiving thyroid for differentiated thyroid cancer. So you can't give somebody with differentiated thyroid cancer placebo to try to suppress their TSH to 0, because that's the treatment, is to suppress their TSH if they have cancer. So what I find interesting about the study, and my critique is, they looked at 3 different TSH values. They looked at a TSH value of 1.0. They looked at a TSH value of less than 0.5, and then they looked at a TSH value greater than 1. And what they found was the more suppressed TSH group seemed to be the group that was, excuse my term, associated with increased fracture risk. So there was a fracture risk that was increased, and it was more frequent in patients with osteoporosis than in patients with normal bone mineral density or osteopenia. Well, yeah, of course. So you take a woman that's menopausal, she has osteoporosis, and you give her thyroid, and you say it causes an increased risk of fracture. Yes, but these women already have an increased risk of fracture because they're osteoporotic, because they're menopausal and not on hormones. The conclusion was vertebral fractures are independently associated with TSH levels less than 1.0, which makes you want to believe that you should not suppress the TSH below 1.0 because it increases fracture risk. That is the conclusion of the study. But I hope that you can understand and see that there's various flaws to the study. There's no control group. They didn't look at thyroid hormone levels. They already were treating women that had osteoporosis from being menopausal, and they found that when they gave them thyroid, that there was an increase in their fractures, but it was an association. It does not prove causation. That's what you need to do, is look at that with control groups, and you probably need to look at groups also in women that were menopausal. In part 1, I presented those studies, and of course in part 2 also. In those people that are taking suppressive doses of thyroid hormone with suppression of their TSH, those women that took menopausal hormones did not have any loss of bone, decrease in CTX, NTX, or fractures. There's lots of other studies, however, that looked at menopausal women that have had control groups, and with the control group versus a thyroid group, there was no loss of bone, no increase in CTX or NTX in comparison with placebo groups. But yet everyone will think, based on this study and the study that I showed at the beginning of this section, that the lower the TSH, the more suppressed it is with thyroid hormone, it can increase the risk of fractures. I hope you understand the flaws in the study, but I also hope you understand that your peers will not understand the flaws in the study. AACE and Endocrine Society will not understand the flaws in it. And they will come away with saying, see, when you suppress the TSH, it causes osteoporosis, period. End of story. You shouldn't be giving them thyroid hormone, and you should never suppress the TSH. Well, what about their dyslipidemia and their body weight and their hyperglycemia and their cardiovascular disease, et cetera, et cetera, et cetera? Tough. Just let them suffer? Yes. Really? Yes. And we ignore all those studies where addition of T3 was beneficial? Yes. So I sort of changed my format to Part 2 course. In the Part 2 course, I used to talk a lot about cardiovascular disease and alternative treatments for cardiovascular disease, and I've now changed it to look at all the data that supports optimization of T3, testosterone, estradiol, looking at outcome studies, not association, but what happens when you give it and looking at outcomes with control groups on what it does to plaque, what it does to plaque reversal, and what it does to cardiovascular disease, and what it does to decrease events, cardiac death, and MI. It's amazing what we have in our literature. It's amazing what you can do with hormones, and it's absolutely amazing what we ignore because we fear it because of the overhype of what happens when you suppress the TSH. And the doctors do not understand that those are baseline association studies in patients with Graves' disease that they've extrapolated to patients that have hypothyroidism, that have the TSH suppressed. Multitudes of different studies showed no harm with high-dose replacement. I reviewed that in webinar 1 and 2. Go back and look at those webinars and those articles. But this is the other side of the coin. This is why your peers continue to think the way they think, why they do what they do, and why they believe what they believe. And I've showed you that data to let you understand why they think the way they think. Don't argue with them. Don't try to give them studies. Don't try to convince them. They already know it and understand it because they've got like this article that just came out, which is similar to the last articles for the last 20 years that I presented in Part 1 that show the same identical thing, but we misinterpret and misunderstand, and you really have to use analytical thinking to understand the complexity of the topic. That concludes today's webinar. If you have any questions, comments, please refer them to Mary Corey and send them to her email address. Thank you very much. Goodbye, Chris. Goodbye, Dana. Goodbye, Mary. Have a nice day. See you next month. Thank you.
Also, that will be available in a folder on EBSCOhost platform. You should be receiving an email in a few days with further information.
I didn't understand what you said. Mary, where is it going to be available? I didn't hear what you said.
We're going to, the articles, we have put it in a folder, and it's going to be on EBSCOhost platform. But we're going to be sending out an email. And, yes.
EBSCOhost platform. Mm-hmm. Okay.
Yeah, the research article. So they should be getting an email in a few days with more information.
Perfect. Thank you.
Okay. Thank you, Dr. Rosier. I hope our listeners enjoyed it as much as I did. Have a wonderful rest of your day.